Hello, everyone. My name is Dr. Ferghal Armstrong, and welcome to Cracking Addiction. And we have with us our usual guest, Dr. Richard Bradlow. Richard, I thought today we'd continue our discussion on alcohol withdrawal, and we'd explore the timings, the natural history of alcohol withdrawal, and perhaps some of the complications if we have time. So over to you. When would you expect an alcohol withdrawal to occur?
Oh, thank you for having me on, Ferghal, and thank you for considering me a usual guest in my second appearance. It's an honour.
That speaks highly of our previous track record guests, doesn't it?
I think and I think we touched on this last week. I think the important thing to keep in mind about alcohol withdrawal is that it is really idiopathic to the individual. So when we talk about a usual pattern, there is a usual pattern across people, but there's a usual pattern to the individual person is much more significant. But, for most people, even people with an alcohol use disorder, their withdrawal is a mild to moderate.
Yeah. So most people have a mild to moderate, but when would it start?
Well, as you said last week, you're technically beginning to withdraw when you're sleeping at night. So, I mean, we really expect people to start experiencing symptoms sometime during the first day when they're not drinking, which in alcohol withdrawal terminology is actually called day 2, because the day 1 is the last day you drank. And it really depends on the person. But I'm expecting, and what time of day they previously drank. I'm expecting it to be about 24 hours.
Yeah. And I think in more severe withdrawal, you might expect it maybe within 12 hours. But yeah, within the first day, 12 to 24 hours. I've actually, we have a policy on our ward that suggests that you don't actually start treatment for alcohol withdrawal until the BAC reduces to less than 0.1. But we've seen patients. I think you've also seen patients where they've had seizures above 0.1. So really, they haven't even cleared the alcohol content in their system, and they're still already demonstrating symptoms of alcohol withdrawal, even with alcohol on board. So it's important to emphasize that, as you say, everyone's different, and some people with severe dependency will demonstrate symptoms of withdrawal upon a reduction, but not yet a cessation or a clearance of their alcohol.
Yeah, and absolutely, and I think when you say people, why we have that 0.1 sort of blood alcohol rule is because we're worried about over-sedation.
Yeah.
And it's why I think often with staff on the ward that can be very protocol driven, they can get a bit concerned when we say, if I see someone that's very tremulous and agitated and diaphoretic and their blood alcohol is 0.2, I'm going to say give them diazepam because I can see they're in withdrawal and you can see that their seizure risk is creeping up. So you can be too protocol driven. And that's, I guess, the value of having an addiction expert such as yourself present, Ferghal, that can give us guidance about when to treat in a more sort of nuanced manner.
Yeah. So how long does alcohol withdrawal last? We're talking, mild, moderate, not any of the complicated stuff yet.
Yeah, 5 to 6 days.
5 to 6 days. Yeah, I would agree with that. And so what do we do for treatment for that? And why do we actually treat alcohol withdrawal?
Yeah. Well, I mean, the simplest answer is why we treat alcohol withdrawal is because untreated alcohol withdrawal can result in death. So that's why we treat alcohol withdrawal. But let's assume that we know you're going to have a mild to moderate alcohol withdrawal.
Yeah.
And we don't think you're going to die, but there is the theoretical risk of kindling, which would be mitigated by medicating alcohol withdrawal. So for those of you that aren't aware of what kindling is a neurological term that refers to electrical activity in one area of the brain, making electrical activity in another area of the brain more likely in the future. So you see it's used quite frequently in periictal and postictal psychosis. But it's also used in alcohol withdrawal, and it's essentially in alcohol withdrawal setting. It means the more you have an alcohol withdrawal, the more likely you are to have a seizure in the future in future alcohol withdrawals. And the way we reduce the risk of kindling is that we medicate your alcohol withdrawal, and it goes back to we have that unmatched sympathetic overdrive, an unmatched endogenous excitatory pathway that's unmatched because you've removed the alcohol, and we ease it in with diazepam. So we give you an exogenous inhibitory pathway, and then we slowly ease that off, and that gives you a much smoother transition into your alcohol withdrawal. That theoretically reduces the risk of kindling.
Right. And so that's one benefit of treatment for alcohol withdrawal. So, simple alcohol withdrawal, we treat it because there's a risk of death, as you say. There's also a risk of kindling. And really, I suppose I think of it as, management of alcohol withdrawal prevents the risk of complications in general. And we'll get to those complications in a moment. But, how often would you expect complicated alcohol withdrawal? Have you got any ideas on that?
Yeah, I'll get to that when I'm ready, Phil. But I feel it rubbed off on me. I think I just had a moment to reflect on my answer there. I feel it was overly biological and medical. I think there's a psychosocial reason why we treat alcohol withdrawal as well, and that's because in addiction, the main motivating driver of addiction would be sort of negative reinforcement, right? So aversive to negative, trying to flee negative emotional states or negative physical states. And if you make someone's alcohol withdrawal as pleasant as possible, then you are making them less likely to have a relapse. And what we want at the end of the day is someone to be able to achieve sobriety and maintain it. And we should be trying to make it as easy as possible for them to do that. So I apologize for neglecting the psychological aspect of why we would treat alcohol. Your question was, though, I beg your pardon, what percentage of people would we expect a more complex alcohol withdrawal? No, that'd be about 10%.
All right. I mean, we're not going to argue about the evidence base, but I've got in my mind 50% of people who are functioning, by definition, not being frequently hospitalized because of their alcohol use. But 80% of people who are not functioning, as defined as either being homeless, jobless, or being hospitalized, they're at risk of alcohol withdrawal upon cessation. So are you saying 10% of all people who drink at risk levels will then, upon cessation, get a withdrawal syndrome?
Look, Ferghal, statistics can be made to prove anything.
Again, I don't want to debate the evidence base.
I think
paper for that.
I think what you said sounded very reasonable. In my mind, I have sort of 10% of patients in general. But then, what does that mean? So I'm gonna back down from it. I think what you said is incredibly reasonable. I don't think it matters in the end. We're going to treat everyone assertively. We're going to make sure everyone.
Yeah. Well, I suppose it alludes to the fact that really, as you said at the very beginning, this is a very personal phenomenon. Everyone is different. So let me put it another way. What are the risk factors that would make you feel that there was going to be an alcohol withdrawal?
So the absolute first risk factor is having had a previously complicated alcohol withdrawal.
Yeah.
That is risk factor number one, and then it's about medical comorbidity and, of course, content of alcohol and co-occurring substance use disorders. So if it's an alcohol, especially with another GABAergic drug, I would be incredibly worried.
Yeah, I think we can agree on that. Yeah. All right, so let's talk about the complications, right? So we know what a simple alcohol withdrawal looks like. We talked about it in the previous episode. The past night phenomena, the autonomic hyperarousal, and the perceptual disturbance. What are the complications that can arise as a result of a suboptimally or even untreated alcohol withdrawal?
So the number one the big red flag complication that we're worried about is death. That's primarily achieved through two methods. That would be alcohol withdrawal seizure, or it would be withdrawal delirium, so delirium tremens. But I was talking to someone the other day, actually, an HMO, who corrected me and says they're moving away from using delirium tremens. You heard of this, Ferghal?
Yeah, it's AWD. It's alcohol withdrawal delirium.
Yeah, I don't like that.
I don't like it either. Delirium tremens. I was brought up in delirium tremens, so of course, I would actually prefer to use that term. It also emphasized to me the difference between tremor and tremens, because when I was a very junior doctor, I used to think that tremor was the main diagnostic criteria for delirium tremens, because tremens. It's
And I
not
understand this is the reason why they've changed the name because of that confusion.
right. All right. Okay. Well, I can't argue with that logic, but
No, I'm sorry. I feel it's the dumbing down of medicine. I don't think it's necessary. I mean, if you have a medical degree, you can understand the difference between a tremor and a tremens. But that's
well, I mean, I think the most important point to make about that is it's in alcohol withdrawal delirium. The key diagnostic feature is the delirium, not the tremor, because tremor is part of basic alcohol withdrawal. But anyway, so we're talking about the complications. So we've got death, we've got alcohol withdrawal delirium, DTs, call it what you will. What are the complications?
seizures.
Yep. And then what else?
Uh, and then what we touched on and alcoholic hallucinosis, which we touched on last week, which is a
Yep.
sort of visual and auditory hallucinations that can actually also occur during intoxication and can last a lot longer post detox.
Yeah. Yeah. And then
And then sorry, beg your
back to
pardon.
you.
Oh, well, then I was just going to wrap it up with then the symptoms of sympathetic overdrive so the diaphoresis, the tachycardia, the
Yeah.
hypertension, anxiety, paranoia, even. And I think what's important there is if those are occurring in someone with medical comorbidities like coronary artery disease, those also can be incredibly dangerous.
Yeah. And then, of course, finally, we've got, thiamine deficiency and Wernicke's encephalopathy. Yeah.
Yeah.
So let's try and approach these. So, I mean, let's recap. Alcoholic hallucinosis. Tell us about that, first of all.
So alcoholic hallucinosis can be auditory or visual hallucinations or tactile. Generally, those sort of generally they are sort of someone describes seeing little black mice on the floor, little black bugs on the wall. They're sort of in the periphery of their vision. They go away when you try and focus on them. And you also hear sort of auditory hallucinations that aren't typical of what you'd imagine a sort of psychotic auditory. They generally don't have that really unpleasant nature to them. So sort of like someone calling your name or music rather than a sort of derogatory auditory hallucination that you expect in a primary psychotic illness.
Yeah. How would you treat that?
I wouldn't. I'd adequately treat the alcohol withdrawal with diazepam.
Yeah. So you just review the diazepam regime. All right. What about the seizures? Tell us about the seizures.
So alcohol withdrawal seizures are generally general. Tonic-clonic seizures that last 30 seconds to a minute. So they're quite short-acting.
Yeah.
They peak in incidence at 24 hours from your last drink.
Yeah.
However, having said that, that is something when we talk about the idiopathic nature of alcohol withdrawal. That is something for someone. Some people say, I have my seizures on day 3, and they do. That's it.
Yeah.
It is completely.
Yeah, there's a statistic that 90% of seizures are completed by 48 hours. That doesn't mean 100% of seizures are completed by 48 hours, and some people will be different. I mean, what do you do with someone who has a seizure on day 6, day 7? I mean, that's a very tricky decision to make. Was it an alcohol withdrawal seizure or was it an underlying epilepsy? Because that's got significant prognostic implications for your ability to drive and further to that, your ability to work, And alcohol.
And also, I'm thinking if someone's having a seizure on day 6, day 7, was there an underlying, alprazolam use disorder that I missed?
Yes.
And that's what I'm seeing now.
Yes. Was there something else going on? So I have a golden rule. I have a mnemonic, actually. It's not a golden rule. 3, 4, 5. 3, 4, 5. That's how I think about alcohol seizures. So 3 represents 30%. So roughly 30% of people who have an alcohol withdrawal seizure will then go into delirium tremens. 4 represents 40. So if you have an alcohol withdrawal seizure, you've got an elevated risk of death by that factor. And 5. So 5% of people will roughly have an alcohol withdrawal seizure. 50% of people will have a second seizure, and 5% will end up with status epilepticus.
With your presuming with all those, that's if you don't intervene.
That's a good question. I don't know.
and my other question is, you mentioned the 40 times your risk of death.
No, 40%.
40% of people that have a seizure.
No. You've got an elevated risk of death by about 40%.
So it's a relative risk.
It's a relative risk, yes. I don't want you to be 40 times likely to die by a seizure. That's not true.
No. But what is the absolute risk of it?
I don't actually know.
I don't know as well. It would be good to. I was asked this the other day by
Yeah.
a clever HMO, and I didn't have the answer. And I showed my due diligence and didn't look it up in between now and then, knowing I would record them.
I,
So
but if anyone's listening to this and does actually know the absolute risk, please let us know. Email Meducate.
I think that would be something that it would be so hard to do because no
Yeah,
one's
yeah, yeah. Especially
medicating
these days,
alcohol.
especially when we've got adequate, appropriate treatments, and because we use Valium. Yeah. So thinking about it, those numbers must relate to untreated alcohol withdrawal seizures.
Yeah.
Yeah.
I'm looking at some statistics now that say that 5% of people undergoing alcohol withdrawal will get delirium tremens, and 5% of people that get delirium tremens will die. And presumably, those are unmedicated alcohol withdrawal statistics.
Yeah.
Therefore, the death rate of alcohol withdrawal is what, a 0.5%? Might be a
Wow.
bit wrong there.
Yeah. I think historically with delirium tremens, the risk of death untreated was 30 to 40%.
Okay.
And that was due to heart attacks, electrolyte imbalances, dehydration, et cetera, et cetera. And with treatment, the mortality rate for delirium tremens is way less than 5%. And, as you say, then probably less than 1%. And certainly, really, in our units, if we had anyone die of alcohol withdrawal delirium, we would consider that as a preventable death. So we don't want anyone to die.
From the coroner, if you had a
Yeah.
death on a withdrawal unit,
Yeah. Yeah.
that should not be happening.
Yeah. Shouldn't be happening. So we talk about seizures. What's the management of seizures within alcohol withdrawal?
Well, I mean, it's still a seizure. It still requires neurological investigation. So, I mean, initially, you want to do your doctor's ABC. You want to make sure the airways are maintained.
Yeah.
You would ideally like to get some more benzodiazepines in them, and you'd
Yeah.
be transferring them to an ED because they've had a seizure. It's a serious illness that requires investigation.
Yeah. Yeah. But if they're in ED, then I think really the key thing is to review their benzodiazepine regime and then possibly consider AEDs. The one thing I would say about the use of AEDs is do not use phenytoin or fosphenytoin, because like in the case of, I think, absence seizures, phenytoin and fosphenytoin have been proven not to be of any use. But, IV Capra, IV clonazepam, those are the drugs that
I
I
would
would
imagine.
be
Well, I imagine modern EDs. I think we're looking at MedHeads very quickly because that's what.
midazolam, yes, midazolam. Yeah. All right. So we talked about hallucinosis, delirium. What's next on the list? Sorry, hallucinosis, seizures. What's next on the list? Not that I've given you a
I
clue.
can't remember what it is. Is it delirium?
Oh, yes. Delirium. So we've talked about hallucinosis. We talked about seizures. Let's talk about delirium. Now, are we going to call this alcohol withdrawal delirium, AWD, or delirium tremens?
Absolutely, we're going to call it delirium tremens.
DTs. All right, we're going to be old-fashioned. Right. Talk to me about DTs.
So, I mean, DT is what you fear the most when you're managing alcohol withdrawal. It's obviously the most dangerous part of alcohol withdrawal, and especially in an older person, it really can be a death sentence.
Right.
I think in my experience, I've come across one person not on a inpatient detox unit, but certainly on a medical ward I came across them a few weeks after they'd withdrawn from alcohol, but essentially they had a lot of medical comorbidities. They had poorly managed alcohol withdrawal. They went into delirium treatments and they had 6 weeks of delirium and then they died. And so I would classify that as death from delirium treatments. They obviously had other medical comorbidities going on that were contributing to the delirium, but I believe if their alcohol withdrawal was adequately managed initially, they wouldn't have died. So it is very dangerous. It peaks in onset day 3, and it can last weeks. Right, and in my story, if there's other things going on, you can flick into delirium and not flick out of it. So it is very concerning. The thing do we have time? I'm sure we have time for a story. I'll tell another story.
Tell us a story.
I think with delirium, especially in younger people, with people that are not as familiar with it, it's easily confused for psychosis. So when I was a second year psych registrar, I got a phone call from a medical ward HMO on one of my calls, and his question was, "There's a woman here. She's 53 years old. She's on the medical ward for a withdrawal of alcohol. She is wandering around the ward, confused, or responding to auditory hallucinations. I'm calling you as the psych reg because my registrar wants to know if you should give 5 milligrams or 10 milligrams of olanzapine because she's obviously psychotic. She didn't have a history of any mental any psychotic illness. So I said to her, well, alcohol withdrawal, when did she come in? 3 days ago. So it's day 3. Oh, okay. And how much diazepam has she had per day? Well, on the first day, she had 40 milligrams of diazepam. On the second day, she had 50 milligrams of diazepam. And today, she's had 5 milligrams of diazepam. And I said, wow, have you considered that this could be delirium tremens? You should get a lot of diazepam into it instantly. And that was, I'm sure those were 2 very confident medical doctors working at a hospital I won't name. But I mean, so it is easy to confuse delirium tremens with something else, delirium in general. And I think that's why it's important when you're assessing delirium, because people often say, well, they're oriented to time, person, place. They can't be delirious. But what you really want to look for in delirium is attentional deficits. So what I like can you say the months of the year backwards?
Yeah.
And if I want to show off and I want to grade the severity of the delirium, I'll ask them to say the days of the week backwards. And then I'll put in my notes. They could do the days of the week backwards, but they couldn't do the months of the years backwards. Of course, it can have some slip-ups because some people love doing the months of the year backwards and the days of the week backwards. Even when they're delirious, they can do that. But you want to do things that assess their attention. So serial 7s, spelling words backwards.
I completely agree with you. I think the hallmark of delirium is an attentional deficit. But the important point to make about alcohol withdrawal delirium, delirium tremens, is that it is a hyperactive delirium. So the little old lady lying quietly in the corner, confused on a medical ward, that's not the picture that we see with alcohol delirium tremens. Delirium tremens is an agitated delirium, as you've already described, walking around, wandering the wards, getting in people's way, and more importantly, getting to the attention of nursing and medical staff. All right. So that's one key difference between delirium tremens and all of the medical causes of delirium, which tend to cause a hypoactive delirium. And secondly, going back to the point that you made about this attentional deficit, I agree with you. That is the hallmark of delirium. Now, when we are firing a bow and arrow and looking at a target, we are giving our full attention to that target. So bow, B-O-W, for me represent the key features of an attentional deficit. So B is backwards, i.e. the days of the week and the months of the year, and also the serial 7s. So, 100, 97, 86, 81, 7. Have I done that right?
193, 86, 79.
79, 72, 65. Thank you. I have to think about that. I must be getting old. Right. So those are all the backwards things. Then we have orientation, which is, do you know where you are, who you are, why you're here, and what's the time of the day? So that's the time, place, person, and purpose. And yes, I agree with you that they in and of themselves cannot diagnose delirium. I think it's still important to assess for orientation as part of an attentional deficit screen. And then the final thing is the working memory. So registration and recall is key for working memory. So, I'm going to say 3 things and repeat them back to me. So that's how I think of attentional deficit. And that is, for me, the hallmark of delirium. But it's got to be a hyperactive delirium.
When I thought of when I heard your mnemonic there, Ferghal, and I thought of bow, I also thought that's a very long bow to draw to get to this mnemonic about delirium.
Some of us require mnemonics because we're getting old. We can't remember.
Well, it's been wonderful to be on, Ferghal, but perhaps we'll have to save Wernicke's for next week.
We'll have to save Wernicke's for next time. All right.
Keep them wanting more.
Richard, thanks very much for your time and your expertise today.
Thank you, Ferghal. Thank you for having me.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.